Good evening, everybody, and welcome to this monthly MedEClasses postgraduate lecture series in which we are going to talk about a very important topic of hypokalemia. This lecture series, as we've discussed earlier, is an event which we organize monthly, and we propose to have 36 such sessions covering the entirety of postgraduate relevant pediatric endocrinology. So we have been running on electrolytes for these last few sessions. We're on hyponatremia, hypernatremia, and today we talk about hypokalemia. Now, hypokalemia is very common in terms of pediatric practice, but Dr. Manoj, what do you think are the major causes? So today I'm joined by Dr. Manoj Agarwal and Dr. Vibha Yadav, who are fellows in pediatric endocrinology, who will be part of this program. So Dr. Manoj, what do you think in terms of from a pediatrician's perspective, how common are endocrine causes of hypokalemia?
So if we talk about the pediatric perspective, then the diarrhea and vomiting is major cause of the hypokalemia. So it is a normal in the for the pediatric, but we have to keep our eye and ear open to not miss the sinister pathology like RAS axis or tubulopathy or the Bartter or Jitterman syndrome, because this can cause the persistent and the chronic hypokalemia. So to identifying etiology is a very major cause in this particular concern.
So, Dr. Vibha, what do you think are the pointers when somebody should start thinking that, okay, this is not a simple cause of hypokalemia, we are thinking of some form of a endocrine cause of hypokalemia?
Like when any patient comes with like a failure to thrive, not gaining weight and having like malnutrition and having multiple fractures, like in the case of RTA, it could be the cause of one of the hypokalemia. And we should not miss it because it would lead to very life-threatening complications of metabolic acidosis. And another another symptoms could be like paralytic ileus or having this could be many problems.
What would you look at in terms of hemodynamic status, which will tell you the likelihood of an endocrine cause? Which parameter you will look at?
So for the hypokalemia, there will be for the ECG you are talking about?
No. So I'm talking about what will be the pointer that this is an endocrine cause. So if this thing is high, you start thinking this is an endocrine.
Sir. Basically, BP. We will look for the BP. If it is high, then definitely there is the RAS axis. It is involved here. And
yes. So as Dr. Manoj and Dr. Vibha have said that the hypokalemia is very common in pediatric practice. We talked about hyponatremia. It is also common, but there are much more endocrine contribution, particularly of SIADH. Hypernatremia, which we discussed in the last session, is usually because of dehydration, or a chronic hypernatremia would basically is equivalent to diabetes insipidus. This is what we discussed. But when we talk about hypokalemia, there are many more acute causes. You may have a gastrointestinal loss, you may have diuretic use, you may have urinary loss, which will be more common. But if you have chronic hypokalemia with hypertension, along with that severe failure to thrive in polyuria, start thinking of tubulopathies and endocrine causes which may become relevant from that perspective. So we'll be starting the session. We'll talk initially about pathophysiology. Then Dr. Manoj will talk about etiology, followed by assessment and management by me. And Dr. Vibha has collated a number of interesting questions which are relevant from postgraduate perspective, which can come from that perspective. So as we have discussed, hypokalemia is a common finding, but often it becomes like a diagnostic challenge, which is there in that perspective. So one needs to be aware and open to the various possibilities which are there. So we had this 2-year-old boy who presented with failure to thrive and had a significant failure to thrive in the form of weight of only 8 kilograms and compromised height with hypokalemia. Now, based upon the workup, and we'll discuss subsequently as to how blood gas becomes very important in here in terms of evaluation, the patient had alkalosis, which was quite significant, and further workup showed a normal blood pressure. Along with that, a hypocalciuric situation and a low magnesium. So we had a child who has hypomagnesemia with failure to thrive with hypocalciuria. The most common diagnosis people make is that of Jitterman syndrome. But the challenge in the evaluation of hypokalemia is not to rush towards unusual causes, because common causes are more important. So what we should consider here was to look at malnutrition. So when we looked at the fractional excretion of magnesium, which was low, it suggested that this was primarily a cause of malnutrition causing hypokalemia rather than a tubulopathy. So we need to have a comprehensive assessment with regards to the evaluation before we reach to a particular cause, because that cause deserves a specific treatment in that perspective. So as discussed, we'll touch base about pathophysiology, followed by criteria and etiology, management, and then we'll go forward from that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got validated modules with regards to different aspects of pediatric endocrinology. We have got our e-learning portal on YouTube, where now there are a large number of videos, and you can also access our courses which provide validated tools for assessment and evaluation. We have specific courses in the form of fellowship in pediatric endocrinology and pediatric endocrinology for postgraduates, cater to specific needs of people at different levels of careers. We do conduct 3 programs on a regular basis in the form of a pediatric endocrine grand round, a pediatric endocrine focused discussion, and this PG lecture series, which cover entirety, and these are available routinely on Zoom and YouTube. All the recordings are there. There are 2 publications which are available through our website, as well as the Kindle book reader and a mobile application which helps in terms of assessment and diagnosis. So from an etiological perspective, hypokalemia can be because of cellular shift. These are acute causes, insulin beta agonist, periodic paralysis, and add risperidone in that perspective, or a extrarenal cause in which you have got a urinary potassium which is low, which includes a GI tract abnormalities like vomiting or NG aspiration, or really cystic fibrosis. Or finally, the most common cause ultimately is a urinary loss where the urinary potassium is high. This could be a RAS-dependent process with hypertension, including aldosteronism, in which aldosterone levels will be high, Liddle syndrome, which is basically epithelial sodium chloride channel activation, or CH variants in which you have got increased apparent mineralocorticoid activity. These are associated with low levels of aldosterone. Finally, you may have a scenario which is RAS independent, which includes tubulopathy, which is associated with alkalosis, and renal tubular acidosis, which is associated with acidosis. So if we talk about hypokalemia, we need to first understand whether there is a cellular shift or not. If the shift is not there, look at urinary potassium. If it's low, we're talking about gastrointestinal or extrarenal loss. If there's a urinary loss, if there is hypertension, we are talking about a RAS-dependent causes. If there is no hypertension, do a blood gas. Blood gas shows you alkalosis, it's tubulopathy. Acidosis will mean renal tubular acidosis. So most important investigations in anybody with hypokalemia, and this I'll connect later on, include the blood gas and the urinary potassium and the measurement of blood pressure. These 3 will give you a classical diagnosis at that point of time.
And as sir very well explained that why hypokalemia occurred, now we will see in the details. So in the diarrhea, there is a high amount of the potassium in the diarrheal fluid, like it is a 20 to 50 millimole per liter. So any cause of the diarrhea directly can cause the hypokalemia. Secondary, if we talk about the vomiting, then vomiting has a lower amount of the potassium than the diarrheal fluid, like 5 to 10 millimole per liter. So it can't cause directly hypokalemia, but due to the excessive acid loss, there will be the alkalosis which trigger the RAS excess, and due to the volume contraction, there will be the RAS activation, and this RAS activation cause potassium loss from the body. But in this particular condition, urinary chloride and potassium will be less than 20 millimole per liter. So in the general pediatric OPD, these are the main causes of the hypokalemia, mainly due to the diarrhea, and vomiting cause the hypokalemia due to the alkalosis and due to the volume loss. So now we will move towards the another entity which is a very important, which is the RAS excess, and which cause the chronic persistent hypokalemia. So what are the causes for it? So any causes for RAS activation or RAS excess cause hypokalemia, like renal artery stenosis, which cause the hyperarenism, which cause the hypokalemia, aldosterone producing tumor like adenoma, hyperplasia, or glucocorticoid remediable aldosterone, where ACTH is working on the aldosterone, where the hypokalemia is more likely. And finally, into the third category, if there is a Cushing syndrome where the excessive cortisol is also working on the aldosterone receptor, it causes the hypokalemia. A-B Liddle syndrome, and CH like 11 hydroxylase deficiency and 17 hydroxylase deficiency also cause hypokalemia. So now we will discuss each and every entity in the details. So if we move toward the adrenal adenoma, adrenal adenoma simply means it is an aldosterone producing tumor. What does that mean? There will be the excessive amount of the aldosterone production from the body. So there will be the excessive amount of the aldosterone production. It mainly patient may present with the hypertension mainly, and there will be the hypokalemia is very less. So only 20 to 50% patient only present with the hypokalemia. But if this patient has been treated by the diuretics, then hypokalemia will be the most common, and aldosterone receptors are more present on the cardiac side also. So this patient may have more cardiac complication than the normal patient. So there are the more complication than the normal essential hypertension one. So this thing we have to monitor, and treatment option is a surgery. So now we will move towards the another entity, which is the very interesting entity, which is the glucocorticoid remediable aldosteronism. Normally, cortisol secretion has been controlled by ACTH, because promoter for cortisol secretion is controlled by the ACTH, and while aldosterone is only controlled by 5 to 10% by ACTH. So normally in our body, aldosterone is not controlled by ACTH. But in this particular entity, what happens? In this particular entity, aldosterone secretion is also controlled by the ACTH. So whenever we have ACTH surge in our body, like in the morning time or in the stress time, that time we have hyperaldosteronism. That time we have hypertension. So in this cause, hyperaldosteronism is caused due to the high ACTH activation. So how to treat this condition? So generally in this condition, we have to block the ACTH secretion. So if we treat this patient with the cortisol, then ACTH will be come down, and finally aldosterone will be come down. So there will be the treatment is cortisol treatment, this patient. This is the autosomal dominant condition, and onset start before the 20 year, and there are the more chances of the complication, and this patient may present with the early hemorrhagic strokes. So now we will move toward the CH variety of the hypokalemia, which is the 11 hydroxylase deficiency. In this patient, due to the blockage of the aldosterone production, there will be the no aldosterone, but there will be the excessive DOC production, which is the potent mineralocorticoids. And due to the high androgen production, this girl child may present with the XYDSD. In the newborn periods, because of the high requirement of aldosterone, this patient may present with the transient salt wasting and hypertension afterwards, and diagnosis has been done by a high DOC level, which is more than 18,000 nanogram per deciliter and borderline high 17 OHP. And how to manage this condition? For manage this condition, again, we have to suppress the ACTH. So cortisol should be required to suppress the ACTH. We need to monitor BP, electrolyte, and DOC is important to follow for the follow-up. And for the women, we need to give the antagonist to the aldosterone receptor, which is the spironolactone. For the women, we need to start with the another molecule, which is the eplerenone and the hydrocortisone. Now, second entity is 17 hydroxylase, which is looking like a 11 hydroxylase deficiency. In this patient have similar manifestation. It present with the hypertension and hypokalemia due to the no androgen production. The boy child present with the XYDSD, and there will be the delayed puberty in the girl. A diagnosis has been done by high DOC level and high corticosterone level. And to manage this condition, we need to start with the aldosterone receptor antagonist, which is the spironolactone in the girl child. And for boy, we need to start the glucocorticoids. And how to monitor this condition? We need to monitor BP and we need to monitor DOC. So now we will move toward another interesting entity, which is the 11 beta HSD2 deficiency. Normally, in our body, there is a two type of the receptor. One is the aldosterone receptor and one is the cortisol receptor. cortisol concentration is much more higher than the aldosterone. So body try to prevent effect of the cortisol on the aldosterone receptor by help of the 17 beta HSD. What does that mean? That means that body having shield effect of the 11 beta HSD to prevent cortisol to work. But in this particular reason, there will be the defect in the 11 beta HSD. So all the cortisol is working on the aldosterone receptor. So there will be the hypertension and there will be the hypokalemia. And how to diagnose this condition? This condition has been diagnosed by the high urinary cortisol to cortisone ratio, which is more than 5. And this patient may present with a hypokalemic alkalosis. And due to the excessive loss of the calcium, there will be the nephrocalcinosis. And if we don't treat this condition, then this patient may present with the renal failure. And how to treat this condition? We need to again start with the mineralocorticoid blocker, which is the aldosterone antagonist. So if we summarize my previous 3 slides, then 11 beta hydroxylase may present in the girl with the DSD, in the boy with the early puberty, and diagnosis is done by DOC and high 11 DOC level. Similarly, 17 hydroxylase present in the girl with the delayed puberty and in the boy with the DSD, and diagnosis has been done by the high DOC level. And third condition, which we just discussed about the 11 beta hydroxylase deficiency, there will be the no DSD in the girl and boys, but diagnosis has been done by urinary metabolism. So now we will move towards the another entity, which is the Liddle syndrome. What is the meaning of the Liddle syndrome? In the Liddle syndrome, there is the hyperactivation of the ENaC channel. So what ENaC channel do in our body? ENaC channel sodium absorbs the sodium and it loses the potassium. So if there will be the hyperactivation, body loses the potassium from the urine. And why it occurs? It occurs due to the low ubiquitin level from the body. So this condition mainly present with the hypokalemia and alkalosis. In this condition, aldosterone is normal. So giving the mineralocorticoid receptor antagonist will not work. So for treating this condition, we need to start this patient with the MRO, right? This is the most important identification. So this patient may not respond with the mineralocorticoid antagonist like a spironolactone, and amiloride is only treatment option for this condition. So if it talks about the diuretics, then there are the 2 main categories. One is the furosemides, which is the loop diuretics, and the second is the thiazides. Both causes the leaking of the sodium and potassium from the body, and it causes the hypovolemia. So as discussed earlier, in the any cause of the hypokalemia, there will be the collecting dust absorb the sodium and secrete the potassium from body. So there will be the potassium loss to conserve the sodium. So in this patient, there will be the high urinary sodium and potassium, and there will be the loss of the chloride and potassium from the urine. So there will be the hypokalemia, and there will be the loss of the proton also. So it present with the metabolic alkalosis, and if treatment has remotely started, then the urinary sodium will be normal. So this is the similar condition as we discussed before, like furosemide excess. So in the Bartter syndrome, there is a defective sodium potassium chloride channel. What does that mean? Body is leaking sodium and potassium from the urine, but from the collecting duct, sodium absorbed and potassium loss. So that means that this patient may present with the salt loss with the hypokalemia, and due to the hypovolemia, there will be the activation of the RAS axis, which cause the hypokalemia, and due to the AVP resistance, there will be the polyuria, and there will be the excretion of the all positive ion from the urine, which cause the nephrocalcinosis, low magnesium, high urinary calcium. So it caused the renal complication, and there will be the low calcium and magnesium in the blood. Gentleman syndrome is similar to thiazide use. So it is less prone for the hypovolemia, and it can cause less severe hypokalemia than the Bartter syndrome. But mainly it present with the magnesium loss. So it is a similar condition like hypokalemic alkalosis, low magnesium, and there will be the high excretion of the urinary magnesium. So it is a similar condition like thiazides excess. If we talk about the diuretics, then in the distal RDA, there will be the defect in the acidification. What does that mean? That means that body is not excreting proton from the body. So body, for maintaining the electric gradients, body try to lose all the positive ion from the urine, like potassium, calcium, and all the positive ion. So there will be the reduced H plus excretion from the collecting duct, and there will be the hypokalemia, and there will be the hypotension. So in this condition, if we treat, then after correction of the acidosis, hypokalemia will be the normal. And this condition mainly improve with the treatment. So if we move towards our last etiology, which is the proximal RTA, in this condition, there will be the loss of the bicarbonate from the urine, and it is the hypovolemia. So there will be the activation of the RAS excess, which can cause loss of the potassium from the urine, which present with the hypokalemia. So if I summarize all the etiology, then hypokalemia occur due to the acute causes, which is occurred by the insulin or which is beta agonist, and diarrhea and the vomiting can cause the main cause of the hypokalemia, which we see in our pediatric OPD. And this proximal RTA, Bartter syndrome, tubulopathy can cause the chronic hypokalemia.